Hi, my name is Dr. Jamie Wood. I am a pediatric endocrinologist and the medical director of pediatric diabetes at Rainbow Babies and Children's Hospital in Cleveland, Ohio. I was also one of the principal investigators in the MannKind trial for inhaled insulin for pediatrics called Inhale One. It means that children with diabetes have more choices and they have more options in how they choose to manage their diabetes. And I think that the standard of care is automated insulin delivery with insulin pumps. And a lot of people will still choose to use automated insulin delivery. And with great outcomes. And people may still want to stay on injections if that's what they choose. But to have a third choice of inhaling their rapid acting insulin just gives them a lot more flexibility. And I think about different niches where inhaled insulin will be, I think, very helpful for certain groups of pediatric patients. But the bottom line is people living with diabetes deserve options and working with their healthcare team to figure out which is the best option for them. Inhale One was a randomized controlled clinical trial. Of course, we could not blind the study because you couldn't tell the difference. You could obviously tell the difference between someone who's inhaling versus injecting. So it wasn't blinded, but we had 230 individuals under the age of 18, and they were randomized to inhaled insulin plus an injected basal or to stay on multiple daily injections with their basal. We followed them for 26 weeks. And then anybody who was randomized to the injected insulin could switch to inhaled insulin for the second 26 weeks. So everyone in the trial got the opportunity to use inhaled insulin for at least 26 weeks. And the primary outcome of the trial was the hemoglobin A1C at the 26-week mark. And hemoglobin A1C is a measure of blood sugar average over the preceding 3 months. And the first analysis is what we call an intention to treat analysis, where everybody in the trial, all 230 participants, are analyzed. And what we were looking to demonstrate is that inhaled insulin was not inferior to multiple daily injections of insulin. We weren't necessarily trying to demonstrate that it was superior. We just wanted to demonstrate that it was not inferior. And when we included everybody in the trial, we were not able to demonstrate that, actually, to be perfectly honest, in that the A1C in the inhaled insulin group at 26 weeks was slightly higher. Clinically, very similar, but statistically a little bit higher. So we didn't meet that non-inferiority benchmark. But then when we did a pre-specified secondary analysis, a sensitivity analysis, we call it, there was one participant who was in the inhaled insulin group who didn't use the inhaled insulin. And so they did not adhere to the protocol and had a very elevated A1C because they were not inhaling. And so when that person was removed from the analysis, in that sensitivity analysis, we did meet the benchmark, able to demonstrate that inhaled insulin is not inferior to rapid acting insulin. So that's the primary outcome. The secondary outcomes were other measures of glycemic control based on the continuous glucose monitoring. And we were able to demonstrate that those were nearly identical, very similar between the two groups in terms of time in range between 70 and 180, time spent below 70, hypoglycemic, and time spent with an elevated glucose. Very, very similar. And then we also looked at patient satisfaction, which in my opinion is one of the most important things to look at in a clinical trial. And the pediatric patients and their parents reported improved satisfaction with their treatment when they were on inhaled insulin. And then the other outcome was that we saw less weight gain in people who are using the inhaled insulin, which is also a desirable outcome. And then probably most important, I mean, efficacy data is very important. And we were able to demonstrate that it was efficacious, but the safety data is is very, very important. And when you're taking a product like this that's already been FDA approved in adults, we have a saying in pediatrics that children are not small adults and that they have different physiology. And just because something's safe in adult does not mean that it will be safe in a kid. And so we needed to demonstrate that the pulmonary function was stable in the pediatric patients, and it was. And so we followed the FEV1, which is a measure of pulmonary function, at baseline and then every 3 months for the year. And there was no statistical difference between the inhaled group and the group that received injections. So that was very reassuring. And then we also looked at episodes of severe hypoglycemia and diabetic ketoacidosis in the two groups, and those were also similar. I think two come to mind. The first is when we looked at subgroup analyses, we tried to see, is there a particular subgroup that seemed to do better than others? And we found that our teenagers, actually, so the participants who are over the age of 13 tended to do a little bit better than the younger patients. And I thought that was really interesting because oftentimes it's the younger kids that do a little bit better because they have their parents helping them a lot more. And what I think that speaks to is that inhaled insulin gives them a little bit more flexibility, a little more spontaneity in their day-to-day life. It's a little more discreet. And I think perhaps a teenager who wants that, they were able to more intensively manage their diabetes and do a little bit better on the inhaled insulin. So I thought that was a cool finding. The second thing, which has not been reported so much because we've published the 26-week data, and then I presented the 52-week data at a conference this fall, is that we enrolled both type 1 and type 2 patients into the trial. But only 5 of the 230 participants had type 2. So we were unable to do a comparison and report on how patients with type 2 did on inhaled insulin. But I thought it very interesting that patients or individuals with type 2 seem not to be so interested in doing the trial. It was difficult to recruit and enroll. And I think that's because youth, primarily adolescents, have type 2, that the adolescents with type 2 now have have more treatment options as well. And they have metformin, are tried and true, but then they have GLP-1 agonists and they have SGLT2 inhibitors now. And so they have a lot of treatment options that is actually preventing them to need mealtime insulin. And so I think a lot of our type 2 adolescents don't need mealtime insulin anymore, which is great. And therefore they didn't really need the trial. So I was hoping to see more of our type 2 participants interested in doing the trial, but we only had 5. Really great question. So inhaled insulin is best described as fast on and fast off. So it's regular human insulin, and it's attached to this technosphere molecule. And when it goes into the lung, they disassociate, and the insulin is absorbed through the lungs into the bloodstream within minutes. And then it's working in like 12 minutes. And then its peak, it's at its strongest, like 35 to 50 minutes. It's at its peak effect. And then it's starting to leave the system and be gone in about 90 minutes. If you compare that to injected insulin doesn't start to work for 10, 20 minutes. And then it's peaking in an hour to 2. And then it's lasting up to 5 hours. So inhaled insulin is more closely mimicking the insulin that our pancreas should be making. It's faster, it's instantaneously there, and it goes away quickly after it does its job. And so when individuals are using injected insulin, ideally, they're injecting their mealtime insulin 20 minutes before they take their first bite. As a kid, or as an adult for that matter, that's hard. It's like, I'm hungry, I want to eat, but take my insulin, I have to wait 20 minutes. With inhaled insulin, first bite, inhale. And it gives them spontaneity. It just gives them flexibility of, hey, we're at a restaurant, I've ordered food, the food arrived. I can just discreetly inhale and start eating. So I think that will really help. So they don't have to wait. And then the second is there's adherence issues, for if someone's choosing to be on injected insulin, there's adherence issues in terms of needle phobia, pain with injections, scar tissue. If you give insulin in the same spot on your body, you can develop what's called lipohypertrophy and have lumps and bumps in scar tissue. And then that eventually can impair the insulin absorption. So somebody who struggles with those issues, they're afraid of needles, they have a lot of anxiety with needles, or they have scar tissue, inhaled insulin would be a good option. And the third thing you mentioned was activity. And it's that same fast on, fast off concept that really helps in that what contributes to low blood sugar during exercise is what we call the insulin that's still on board. So insulin that the person has given themselves for a meal or for a high blood sugar and they give it before they exercise or do sports. And that insulin is still in their system. And because injected insulin lasts, 4 hours, that tail of insulin can cause late hypoglycemia, particularly during exercise. But with an inhaled insulin, an athlete or a kid who's doing soccer on the weekends could have that meal or correct that high sugar before their practice and have that insulin already out of their system before they start practice. And so we anticipate that they'll have less hypoglycemia with sports. One of the clinical trial participants at our site is a football player. And he'd come home from school and have a large meal, hungry, and he would inject insulin for that. And he really struggled with hypoglycemia during football practice after that snack. But when he was randomized to inhaled insulin, he also had a needle phobia, same kid. And when he was randomized to inhaled insulin, he could go home, have his meal, and then practice was 2 hours later, and that inhaled insulin was gone. And so he experienced far less hypoglycemia during his football practice, which he loved. Well, interestingly, the American Diabetes Association publishes their consensus guidelines, their practice guidelines every January of each year. And for the first year, inhaled insulin is listed as an option that should be discussed with every patient. Well, now that patients down to the age of 6. And so I think it needs to be presented as an option. And what I do, because being part of the clinical trial, we had 8 participants in the trial. And then I have a lot of young adults using inhaled insulin because it's been approved for adults since 2014. And it's really a discussion about what are your options. So your options are to use multiple daily injections, insulin pens. About 80% of our patients in our practice here at Rainbow choose to be on automated insulin delivery pumps with CGMs. But then also explain that, say you don't want an insulin pump, say you don't want to have something on your body, or say you have a hard time with allergies to the adhesives and you don't want a pump. And there's a lot of people that they don't want to manage their diabetes with a pump. And so you can say, okay, well then your options are you can inject insulin with pens or you can use inhaled insulin. And it just needs to be presented as a choice. And I think those niches that we talked about will be important to offer as an option for those particular patients. If there's a needle phobia, if that they struggle with sports, for example. And I also imagine that moving forward, now that we have this approval, is that it's going to be, I think patients are going to mix and match. And right in the trial, they only could use inhaled insulin. They took their basal injection and they only could use inhaled insulin for everything. But in real life, they could inhale insulin for some doses. They could inject insulin for other doses. They could use an injection for a heavier, higher protein, higher fat meal that needs longer coverage, and they could inhale for a faster acting carb meal that spikes, or they could use inhaled insulin for their sticky highs that are just being stubborn, because you can see a much faster, quicker resolution of a high sugar after an Afrezza dose. And I think we're going to see people use inhaled insulin as an adjunct to pump. And I know that's happening in the adult world. It's also being studied how you can do that safely to add inhaled insulin. So I think it's going to be a tool that people will pick and choose. It's not going to be an all or none.